right. Thank you, everybody. Thank you, Dr. Ayler. The topic I'm going to be presenting today is anal cancer and HIV positive men who have sex with men. The objectives for my talk are going to be to review the burden of anal cancer in HIV positive MSM, review anal cancer screening, review the effectiveness of anal pap smears, and review some ongoing studies to see what information they may provide in the future. So anal cancer is relatively rare in the general population. 0.2% of men and women will be diagnosed with it in their lifetime, and it represents about 0.5% of all new cancer cases in the U.S., and I believe it's about the 26th most common cancer in the general population. In 2016, it's estimated there's going to be over 8,000 new cases, as well as over 1,000 deaths, predominantly in women. Again, this is the general population, and with a median age of diagnosis of 61 years of age. Most malignancies in the anal region, there's multiple different kinds of cancers, but the one that we really think about when we talk about anal cancer is squamous cell carcinoma, which at least makes up 65% of all anal cancers. But though rare in the general population, in the HIV infected population, it's actually the fourth most common cancer, behind non-Hodgkin's lymphoma, Kaposi sarcoma, and lung cancer. Anal cancer, just like cervical cancer, occurs at the squamo-columnar junction epithelium, or the transition zone. The transformation zone. The transformation zone is at the dentate line of the anal canal and of the cervix, and both are characterized by high turnover epithelium, which is thought to be particularly vulnerable to malignancy-inducing genetic alterations, especially after they get infected with HPV. This illustration, is just to show where the dentate line is, just right over here. So that's where the transformation zone is. And given the shared histopathological features of anal cancer and cervical cancer, we use the same nomenclature to describe the findings. So there's two basic classifications. There's the cytological one and the histological. The cytological classification is for anal cancer. We use the BETHESDA 2001 system, and so it basically classifies them as either one, it's completely negative, or you get atypical squamous cells, which are subcategorized to atypical squamous cells of undetermined significance, or atypical squamous cells cannot rule out HSIL. Then there's HSIL, which is low-grade squamous intraepithelial lesion. HSIL, which is high-grade squamous intraepithelial lesion, and then obviously squamous cell carcinoma. The histological classification, which we get on biopsy and pathology, is based and graded on severity. So the higher it is, the more severe it is, and the more involvement there is. It's classified by AIN1 all the way to AIN3, and AIN stands for anal intraepithelial neoplasia. And the figure on the right is taken from a paper that shows on the left-hand column, they use some immunohistochemical staining to show the abnormal cells. So AIN1 is the involvement of the lower one-third of the epithelium. So on the left is the top left box shows that the bottom one-third of the epithelium is involved. AIN2 is when you involve at least two-thirds of the epithelium, and so that's the box right below it. And AIN3's involvement of the entire thickness of the epithelium, so that's the box right there in the bottom. And here's just a table showing the relationship between the cytology and histology, that atypical squamous cells, or ASCUS, or atypical squamous cells cannot rule out HSIL, is related to histology by its atypia. LSIL is AIN1 in histology, and HSIL is AIN2, AIN3, and carcinoma in situ, and then cancer throughout. AIN1 is not considered to be precancerous, but actually may progress to AIN2 and AIN3, which are considered to be precancerous. And AIN3, just like in cervical cancer, which is CIN3, it has the highest risk of progression to cancer. The risk factors for anal cancer, particularly, are the top two ones right there. HPV infection, more commonly HPV 16, then HPV 18, and then there's the rest of the high-risk HPV genotypes. Then HIV infection itself is a risk factor for anal cancer. History of anal warts or condylomas, history of anal receptive intercourse, history of smoking, history of being immunocompromised. Gender and race ethnicity can also play a role in who gets anal cancer because there's higher rates in women, and in African Americans it's more common in men than it is in women. Um, and also, lastly, having other similar regional cancers is a risk factor for anal cancer. So if you have a history of cervical cancer, vaginal cancer, vulvar cancer, or penile cancer, you have a higher risk. This table or this graphic shows the incidence rates over time of anal cancer. This data is from 1975 to 2012, and kind of just in general shows the overall incidence has been going up over the years, as well as the incidence rates of deaths. And so, as far as the incidence rates in the general population, in men, the incidence rate is 1.5 cases per 100,000, and women's 2.1. Compare that to HIV-infected patients, where the incidence rates are much higher. In HIV-infected MSM, mainly, this the highest I actually saw, which is like 131 cases per 100,000 person years. Then other HIV-infected men were 46 cases per 100,000, and then HIV-infected women is 30 cases per 100,000. So the HIV population in general has a much higher incidence rate than the general population. This graphic also shows kind of the incidence rate between HIV positive MSM and HIV negative. The top here is the HIV positive MSM. Here's incidence rate in the x-axis, and here's HIV negative MSM. So you can see the incidence rate's much higher. Here they also kind of split up the HIV positive MSMs, the incidence rates pre-heart era and then post-heart era, just to show that even though after the advent of highly active antiretroviral therapy, the incidence rates of anal cancer are still very high, and it's actually higher than prior to that. So, like kind of how I mentioned before, like cervical cancer, HPV infection plays a significant role in the pathogenesis of anal cancer. Infection of the actual epithelial cells can lead to loss of cell differentiation and development of clonal proliferation, leading to cancer. And HPV has been associated in more than 80% of cases of anal cancer, and predominantly HPV 16 at 87%, and HPV 18 was 6%. And given that HPV is a significant risk factor or a significant part of the pathogenesis of anal cancer, knowing how prevalent HPV is in the HIV population is significant. So in this review article, they showed that the prevalence of HPV infection was 86% in HIV positive MSM, and predominantly in HPV 16, comparing that to 57 to 61% in the HIV negative MSM. Kind of showing the same thing, HIV positive MSM and HIV negative MSM. On the left-hand side, there's the top shows the HIV positive MSM, shows the incidence, the prevalence, is much higher than the HIV negative MSM. And on the right-hand side, you see the HIV positive MSM's prevalence of high-risk HPV is much higher compared to HIV negative MSM. Now that we know that HPV can cause or contributes to the development of anal cancer, and HPV is more prevalent in HIV positive MSM, we want to kind of see how that affected the incidence rates of anal cancer over time. So this study here, the HIV/AIDS cancer match study, gathered data from the beginning of the HIV epidemic in the early 1980s, and kind of looked at the number of cases, look how much of those cases had HIV-infected patients, and then kind of looked at how those cases contributed to the overall incidence rate. So in here, they got, in this set of cases, they looked at 20,533 anal cancer cases, out of which 1,665 were HIV-infected patients, and the majority of those HIV-infected cases were patients who had AIDS. And As far as the demographics, they noted that HIV-infected cases tended to be younger. 74.2 were diagnosed between the ages of 20 and 49. They tended to be predominantly male and also predominantly MSM. Comparing that to the HIV uninfected cases, which tended to be older, over the age of 50, and predominantly female, which is pretty consistent with the data from the general population. And so here's how they tried to see the effect of the HIV epidemic on incidence rates of anal cancer. So they noted that the anal cancer incidence rates in males increased 3.4% annually overall between 1980 and 2005. And then they excluded all the HIV-infected anal cancer cases, and they noted that the rates only increased during this period of time annually by 1.7%. They noted that the incidence rate was, when they excluded those cases, was significantly affected in males between the ages of 20 and 49, and African Americans as well. But when they did the same thing, when they looked at HIV or females in general, when they took out the HIV-infected cases, they noted that the change or the incidence rate actually didn't change. That the rate of increase was still 3.3%. And this is a figure from that paper. The left-hand column is the males, the right-hand column is the females. In the top left, they kind of show here, again, the incidence rate over time, that it's going up in general. The solid black line is the whole general population, all the anal cancer cases. When they excluded the HIV-infected cases, you get the dashed line down here, so you can see the proportion that the HIV-infected patients contributed to the increased incidence rate. Here they broke it down between ages, and as you can see, as we mentioned before, that the age group of 20 to 49 is where you see that the proportion of HIV-infected anal cancer cases contributed a lot more in the increased incidence rate. And compare that to females on the right-hand side, that they did the same exact thing, but when they excluded the HIV infected cases, there wasn't a significant difference between the increased incidence rate over time. So HIV-infected anal cancer patients make up a significant proportion of the overall anal cancer population. HIV-positive MSM have a highest incidence rates of anal cancer among the general HIV-infected population. HIV-infected MSM cancer cases make up a significant proportion of the increased incidence rate since the start of the HIV epidemic. So given that, we're trying to figure out how we can detect or try to prevent anal cancer, and particularly these high-risk groups. So as far as anal cancer screening, the whole purpose of this is, again, trying to detect these high-grade squamous intraepithelial lesions, as HSILs, in effort to try to reduce the incidence of squamous cell cancer. Currently, whatever recommendations or guidelines that are out there and these high-risk groups usually involve the use of anal pap smears. And if you do get an anal pap smear and they come back abnormal, pretty much all of them recommend that you refer people for high-resolution anoscopy with biopsy. Anal pap smears were introduced in the U.S. from Europe in the early 1990s as a primary screening tool for premalignant anal dysplasia. The hope for anal pap smears was kind of the same thing as cervical pap smears, that by using this we can reduce the incidence because of the success that cervical pap smears have had, because cervical pap smears have been attributed with decreasing the incidence of cervical cancer by almost 80% since the inception of it, like in the 1960s. And the sensitivity and specificity for anal pap smears, the estimates range widely between 69 and 93% and 32 and 59%. The sensitivity is pretty comparable to cervical pap smears, but the specificity is not. It's actually a bit lower. Here it shows from paper just the prevalence of abnormal cytology in HIV negative and HIV positive MSM. And it's just trying to highlight that at baseline, HIV positive MSM have a higher prevalence of abnormal cytology compared to HIV uninfected men. In HIV uninfected men, which is on the left-hand side, out of the 750 participants in the study, 25% of them had abnormal cytology at baseline. compared to HIV-infected patients, where pretty consistently, regardless of the CD4 count, their prevalence was much higher. So at over a CD4 count over 500, it was 38% had abnormal cytology. And it goes all the way up to 47% in people with CD4 counts less than 350. This breakdown also kind of shows that the lower the CD4 count, the higher the prevalence of abnormal cytology. And going back to the issue about specificity and also how predictive cytology is to what kind of grade histology you're going to get. Here, this kind of small study just looked at, retrospective study looked at 153 cases, and then kind of looked at minimally, or the abnormalities of cytology and how they correlated with the histological grades. So here, 102 specimens were taken which showed minimal abnormality, which was ASCIS or LSIL, and they saw what kind of histology that resulted in, and they noted that it was pretty much across the board. It wasn't very specific, or it wasn't very predictive of what grade histology you're going to get. So if you had minimally abnormal cytology, 21% of them having normal histology, 42% were low grade, and 37% were high grade. But when they noted that when you had high grade abnormalities on cytology, that it was a bit more predictive of high grade histology, because here, out of the 32 specimens they had, 75% ended up having high grade histology. Also, it's important as far as the results of in Pap smears, that if you do have HSIL on cytology, that you have an increased hazard of progression to invasive anal cancer, which is, again, similar to cervical cancer. And also kind of an important data point, that HIV-infected patients with a baseline HSIL had an estimated 5-year probability of invasive anal cancer of about 1.65%. There's different studies that quote kind of different numbers, but this is actually kind of in the lower end. I've seen like 11%, 3%. All right. So as far as screening, HIV positive MSM have a higher prevalence of abnormal baseline cytology than HIV negative MSM. High grade cytological abnormalities on anal Pap smears are more predictive of high grade histology. And patients with HSIL have an increased hazard of progressing to invasive anal cancer. So taking all of that into account, we're going to look at the current recommendations and guidelines. There's no set national guidelines, and these two slides here basically show the different organizations that have some sort of recommendation or guideline. I'm not going to talk about all of them. I just wanted to show that they're out there. But two of them I do want to talk about. The first one is New York State Department Public Health and AIDS Institute, which came out with the first official guidelines, at least for New York State, in 2007. That's the last time they were updated, but they're currently under revision at this point. Their recommendations, first, at baseline, is to when you do your annual physical exam in HIV-infected adults, that first you should always check for any kind of anal symptoms that would be suggestive of something underlying that's abnormal. You should always perform some kind of visual inspection, perform a digital rectal exam. Here they recommend that you should refer women with cervical HSIL or any patient with any kind of abnormal anal physical findings for high-resolution anoscopy with biopsy. And then for HIV-infected populations, they recommend anal cytology at baseline and then annually for men who have sex with men, any patient with history of anal genital condylomas, and women with abnormal cervical and vulvar histology. And then finally, just like pretty much everyone else, that if you do have abnormal cytology, they recommend getting high-resolution anoscopy with biopsy. And this is an algorithm, the screening algorithm that they have. So you screen with the anal Pap smears. If it comes back normal, you just continue your annual Pap smears. If it comes back abnormal at all, then you go directly to a high-resolution anoscopy with biopsy. And depending on those results, then you kind of either go back to annual Pap smears, or follow with annual high-resolution anoscopies for AIN1, or actually treat AIN2 or AIN3, which are the ones that are the precancerous lesions. And so here I wanted to also mention, I want to bring up what the IDSA kind of talks about at all about this. So the HIV Medicine Association of the IDSA came out with the 2013 update on the primary care guidelines for the management of persons infected with HIV. Under the section of screening for anal HPV, they said that MSM, women with history of anal receptive intercourse, abnormal cervical pap smears, and all HIV infected patients with genital warts should have anal pap smears, but they classified this as a weak recommendation due to moderate quality of evidence. So should we be doing anal pap smears? Something against or would include that there is no randomized controlled trial showing any improved survival with anal dysplasia screening. Also, the natural history of progression from AIN to anal cancer is really unknown at this point. Cytology also appears to underestimate the grade of dysplasia compared to corresponding biopsy results. This more so argues against pap smears in general, but not necessarily about screening. They feel like just because the pap smears are not so great as far as being very specific, that they might not be the optimal screening choice. Also, then progression rates from AIN to invasive anal cancer seem to be substantially lower for anal cancer than cervical precancerous lesions. So I didn't really mention the data on that, but it's been shown that the progression rate's a lot lower. Then treatment of anal HSIL has not yet been proven to reduce the incidence of anal cancer. So treating these precancerous lesions, there's no data to show that it actually decreases the incidence of anal cancer. And then finally, the treatment of anal HSIL is not yet optimized. There's no success rates of the treatment of single lesions is approximately 70%, and retreatment is often necessary. And so some reasons for it, anal cancer, again, it can cause significant morbidity and mortality. HIV positive MSM particularly have significantly higher incidence rates of high-risk HPV and precancerous lesions of HSIL. And the incidence of AIN and anal cancer in general is rising, especially in the HIV positive MSM population. And anal pap smears at least are known to be very sensitive and able to detect precancerous lesions. And since we have treatment available, we should still kind of pursue that. So in the future, there's a couple different studies that are out there. If you go into clinicaltrials.gov to see what's ongoing right now, I just wanted to highlight two of them. The first one is the study of prevention of anal cancer. It was looking at HIV positive MSM and HIV negative MSM, and following them at baseline and then on interval regular follow-ups, and performing anal swabs for cytology and HPV testing and high-resolution anoscopy over a span of 3 years. So it's a prospective study, which is going to give us a lot of information of how useful these screening tools are as far as detecting what they need to detect and how useful they're going to be once they're implemented in screening programs. Also, since it's a prospective study, it's going to help us give a little more information on the rates of disease progression and regression, as well as some of the predictors in the spectrum of anal dysplasia. And then lastly, the anchor study, the anal cancer HSIL outcomes research study, is going to be a study that's going to look at HIV positive men and women with biopsy proven HSIL and actually put them in either a treatment arm or a close observation arm. And this study is actually going to be able to, hopefully, it's going to be to tell us whether treating these precancerous lesions actually is going to reduce the incidence of anal cancer. So this is probably going to give us the most information. In conclusion, anal cancer incidence rates are rising. HIV positive MSM have a higher incidence of anal cancer, particularly within the HIV infected general population. Use of anal pap smears and high-resolution anoscopy can be used to detect precancerous lesions. There are recommendations and some form of guidelines out there for anal cancer screening, if you want to take a look at that. And there are studies in progress that are looking into answering questions of how useful cytology, HPV testing, and HRA is for screening for anal cancer, and whether treating these precancerous lesions will actually reduce the incidence of cancer. So my final thoughts would be that anal cancer screening, especially in HIV positive MSM, has the ability to detect precancerous lesions. And given that there is treatment available, I think it seems reasonable to pursue development of screening programs while we're still awaiting more data.